Welcome to this podcast from the National Institute for Health Research, the NIHR. This episode is about the rising numbers of young people with depression. Services are struggling to meet their needs, and many young people have to wait months or longer to access the talking therapies that could help them. We'll be looking at what help is available and exploring the difficult question of when antidepressant medicines can be the best option for a teenager with depression. My name is Helen Saul, and I'm the Editor-in-Chief of the NIHR Evidence website, where you can find our latest collection of research on antidepressant use in young people. I have two guests with me today, and I'll let you introduce yourselves. Welcome, Bernadka.
Hello, Helen. My name is Bernadka Dubicka. I'm a consultant child and adolescent psychiatrist with over 30 years' experience working in the NHS, treating young people with depression. And I'm also a researcher with a special interest in young people with depression and professor of child psychiatry at the Holland York Medical School at the University of York, an honorary professor at the University of Manchester, and a consultant at Greater Manchester Mental Health Trust.
Thank you, Bernadka. And Felicity.
My name is Felicity Jane Allman. I have lived experience of depression while I was a young person, and I'm now a medical student in Newcastle.
So we know that more and more children and teenagers have poor mental health. And Felicity, you kindly agreed to share your experience of depression. So I wonder if you could describe your depression and give us an idea of how old you were when it started.
I'm happy to share my experiences. Putting a specific date on when I became depressed is tricky, but I do know I was about 14 when I started noticing a particularly sort of low mood. I was in a circle of friends who were all kind of having a bit of a tough time, and we're using cutting as a form of self-harm to deal with emotions. And I almost remember, when we think about talking therapies, the most popular one, CBT, that's looking at your thoughts, your feelings, your behaviours. And it's interesting because I feel like the behaviour almost came first. I think reflecting on it as an adult, it probably didn't, but I was aware that I was cutting to deal with emotions before I was even aware that the emotions were really there. So 14 was when I think it probably started in earnest. And then by the time I was 16, I was spending a lot of time in bed. I was having a really tough time. And I took an overdose of paracetamol, which is what sort of brought me into services, and started a kind of a journey of recovery that took a really, really long time. Depression's still something I live with now. But I do remember as a young person, not really knowing where to go, who to turn to, and the adults around me not really knowing what to say or do to be helpful.
Can you tell us what it was that you were experiencing?
It's really difficult now that I know so much clinically. It can be quite difficult to look on myself, look back and not remember those experiences with a clinical eye. But I certainly had that loss of joy. So things that used to be fun and meaningful for me were no longer fun and meaningful for me. I felt very unhappy with my appearance. I had quite bad acne. I had this uncontrollable hair, and kids can be cruel. And so I was always the butt of quite a few jokes. And I think I really struggled. I think some of them probably weren't meant to be nasty jokes, but I think because some of them were, I perhaps struggled to know when people were joking and when people weren't. I remember this distinct feeling of not being cool enough. And so I didn't get invited to the parties, perhaps, that my friends were getting invited to. And that probably became a bit of a self-fulfilling prophecy, because the more I came to resent those people, the more I would have isolated myself. I just remember spending a lot of time alone, a lot of time watching my grades dropping. I'd always been a high achiever, but my grades were dropping. I didn't really feel like I had anyone to talk to, and finding a lot of relief in just sleeping, just being in bed, and sleeping a lot, and sleeping away quite a lot of my teenage years, and not in the usual grungy teenager sleeping all day, making quite a deliberate choice to be under the covers because it just didn't hurt quite so much.
Sounds extraordinarily painful, Felicity. I'm so sorry you went through that. But Bernadka, I imagine that this kind of experience is familiar to you.
Yeah, thank you so much for sharing that, Felicity. But yes, it's horribly familiar from the many, many stories I've heard from young people over the years. I guess there's a few things I'd like to just highlight, Felicity, in terms of what happened to you and in terms of what I see. And that is, firstly, you had to reach crisis point from the sounds of it before you got help. You took an overdose before you got the help you needed, whereas you've been struggling for quite a few years from the sounds of it before that. And that just illustrates how important it is to try and get that help and support early, because you sort of really described well that horrible vicious cycle, that spiral despair people get into when they're feeling depressed. And then as you become more and more withdrawn, you lose more and more contact with people around you, and it becomes even more difficult to break out of that cycle. And that is why it's so important that young people do get help early on, because we know that the more entrenched those sorts of behaviours and feelings become, the more difficult it is to help people. And the tragedy is that we're seeing more and more young people turning up in accident and emergency departments over these past few years. It's just escalated since the pandemic. First appearing in crisis to seek help, whereas those young people deserve better help from services and should have had that help much, much earlier on. And of course, it's not only better for the young person, their families, it's a lot better for services, and economically it's a lot better if we can give that support much earlier on, rather than wait until young people fall into crisis.
Thank you, Bernadka. Could you outline for us the current guidelines for doctors who are treating young people with depression?
So the current guidelines are based on the NICE guidelines. They were originally drafted in 2005, and there's been some update in terms of psychological treatment more recently. The most important things to draw out from there is, firstly, if a young person has relatively mild depression, is that the professional should wait and watch and see for a couple of weeks to see if things improve by themselves or not. And that's actually quite a sensible piece of advice for those young people who don't have severe depression or have lots of other risk complications associated with that, because it is often difficult to tell which young people are going to improve. I've certainly seen in my experience, it's simply that acknowledging the problem, approaching somebody, having someone listen to their problem, that in itself can be a bit of a kickstart in terms of recovering for some young people. However, if things aren't improving over those first few weeks, NICE then suggests that young people and children with mild depression should be offered some form of psychological treatment. They suggest cognitive behaviour therapy as one form of treatment. And there are many charities like COOF, for example, that do now offer online counselling, which is often informed by cognitive behaviour therapy. And there's a lot of charities like COOF doing excellent work really in that field. However, if there's no improvement following that, then or a young person's moderate severe depression, they should then get a referral to specialist services, or CAMS as is otherwise known. Once young people reach CAMS, they should then get a full proper assessment. We call that a biopsychosocial assessment, in other words, looking at biological factors, things like physical health problems, genetics, for example, looking at the social situation and the environment the young person's living in, because that is so important in terms of how that might affect mood. And also looking at psychological factors as well. For example, if a young person has got lots of anxiety or other factors like that. And once that full assessment's been done and we've looked at the strengths of that young person, their family, and also things that might, what we call risk factors, things that make improvement more difficult for that young person, then we can devise a plan of action and treatment plan to help that young person. But NICE very much state that first treatment approach should be psychological. And they suggest a number of therapies. However, in the more recent guidance, they have suggested if a young person is particularly depressed and the clinician feels it's appropriate, and that should be a child adolescent psychiatrist, then fluoxetine, which is a particular form of antidepressant, can be prescribed alongside a talking treatment first line. So for some young people that might be considered, but for the majority, they should be offered a psychological treatment after a full assessment.
Felicity, how similar was your experience of treatment to the guidelines?
I mean, in some ways it's comparable, and in other ways not. Obviously, I didn't access services initially through a GP. when I did come to the attention of services, which was through the liaison psychiatry team at the General Hospital, I had one-to-one CBT, so cognitive behaviour therapy, the most common talking therapy at home for a course of months, which I don't think is available now. I was really lucky to have that, and I formed a really close relationship with the therapist who came to do that, and that was a CAMS service that was offered locally. And I don't know how much I really understood CBT. I don't know how useful it was in the sense of I could really process those thoughts, feelings, and behaviours. But I do completely agree that just having somebody to talk to, I had an hour a week where somebody sat in the living room with me and said, how has your week been? And I just vented. And sometimes it was good and sometimes it wasn't good. And I could tell her that I had a bad day and I cut myself. And there was no thought of punishment. There was no telling off. There was, oh, well, let's explore that. What made you feel so bad? And it was wonderful. And I think in reflection, a lot of people could have played that role for me. And I hope that most young people would have someone to play that role for them. It would be amazing if there was a greater provision of services. But I do think so much of it is the relationships. And in terms of medication, I remember being offered, certainly before I was discharged from CAMS, which was when I was 18, I remember medication being talked about, and I remember declining that. But I don't remember any other discussions around medication. CBT seemed to be the number one option, and that's what I had.
A point made in the collection is that mental health services are struggling to meet the demand. Antidepressant use in 12 to 17-year-olds doubled between 2005 and 2017. That could indicate that young people might not be able to access talking therapies or might be waiting a long time to see someone. So, Bernadka, I wonder if you could talk us through the current situation.
Felicity's right to say that CBT might not be that freely available, but it is the most common therapy that is offered within CAMS services. But the frightening situation is that even back in 2018, which is when the Care Quality Commission did a review of CAMS services, they found that some young people waiting up to a year for therapy. That was before the pandemic. That was before we had the huge increase in prevalence of mental health problems, particularly emotional disorders amongst young people since the pandemic. And we know demand has escalated massively since then. And alongside that, our workforce just is really struggling to keep up. And for example, we sort of around 1 in 12, I think, child psychiatry posts are vacant, and the same goes for mental health nurses and psychologists. So we are really struggling to meet the huge demand in terms of mental health problems that young people are presenting with, and really struggling to meet the guidelines set by NICE. And I know that, my service and services up and down the country, that some young people are still waiting up to a year. That will depend on urgency. So CAMS services will see young people who need to be seen urgently, for example, may have suicidal thoughts or tried to harm themselves in the way Felicity did much more quickly. But then, of course, you've got lots of other people, as Felicity was struggling in the early years of depression, who would be better off helped much earlier on. But it's really hard for them to access support because CAMS have to prioritise young people that they see that have more urgent need of help. So yes, unfortunately, waiting lists can be sort of months up and down the country. And at the moment, just started to run a National Institute of Health Research trial, see if we can try and deliver briefer psychological intervention much more quickly using practitioners that are newly qualified, and see if we can use that workforce to try and help many more young people quickly earlier on.
Do you think that would have helped you, Felicity?
I think if it hadn't been gone on so long, I think if I hadn't had what was quite like a festering wound of depression, I think, I think we know in a lot of conditions, mental health conditions especially, but even in physical health, if you can get there early, you have better outcomes. But I think a big problem is, if you think that how young I was when it all started, I would have had to sort of come out, as it were, about how things were twice, because I would have had to tell one of my parents and then tell a GP, because as a 14-year-old, I wouldn't ring up my GP and make appointments for myself. So accessing those services, I think, would still have felt like quite a hurdle. I think for adults, it's much easier to say, oh, go speak to your GP or self-refer. I think I wish it had been nipped in the bud. I think it would have given me a few more years, I would have had fewer years of struggling, essentially. But yeah, unfortunately I didn't. And I hope that's a service that becomes available for other young people.
Can I just add then, Felicity, because I'd also like to say that what has been happening in the past few years is that the government has introduced mental health support teams into schools, and that's still a developing programme. But more and more schools should now have access to a team who've been trained in helping young people with mental health problems who are in that mild to moderate range of difficulty, as things were with you earlier on. And that's important, firstly, try and pick up young people earlier on at school, which is probably more accessible than, as you say, going to see a GP. And also, so one of the things you mentioned earlier, importance of having somebody trusted you can talk to. And we know from our national prevalence survey that teachers were, in fact, the most trusted professionals that young people found they could talk to. So there's lots of reasons to think that's a really positive intervention. Of course, we need that process to happen a lot more quickly for all schools to have mental health support teams really quickly. And part of that programme is that each school will have a teacher who's a mental health lead within that school as well. So the sooner that programme can be rolled out, the better, to try and help young people in those earlier stages.
Absolutely.
So the guidelines and best practice suggest the central role of talking therapies, but we know that young people are taking antidepressants. So I'd like to explore now which drugs they should be given. It's a question that's been well studied in adults, but less so in young people. The collection noted that a review of research on depression in adults could draw on 522 trials. A similar review in young people was based on only 26 trials. But even so, it brought together 5 recent reviews looking at which drugs are safe and effective in children and teenagers. So, Bernadka, how would you interpret these reviews? Which drug or drugs are the most effective for young people?
I mean, first, we don't have much evidence to actually look at. But of the evidence we do have, and of the reviews that you mentioned, and as mentioned within the reviews as well, there's been a very good recent Cochrane review, which has looked at this in detail, published last year. The problem is that the majority of the trials that have been done in children and young people have largely been done in the States, have largely been run by drug companies, and have largely excluded exactly the sorts of young people that we would consider antidepressants for in the NHS in this country. In our studies in the UK in the NHS, we found that there's no such thing as pure depression. The vast majority, more than 90% of young people that come to see us are complicated. They've got lots of other difficulties, usually lots of anxiety problems, potentially behaviour issues and other problems as well. And we would include those in our studies, but those sorts of issues may well be excluded from studies that have been done. So we can't actually answer the question, how well do antidepressants work in the most complicated, risky group of young people that we see in CAMS? So that's a big caveat before I go on to say anything else about which drugs, about the quality of the data that we do have. In terms of which medications, NICE recommend fluoxetine first line, and that's still been confirmed by the recent review mentioned in your report, in our report. And also the recent Cochrane review also lists sertraline, which is mentioned as second-line drug within NICE, and also escitalopram. However, the NICE guidance in relation to medication, very old now, they go back to 2005 and haven't been updated. They suggest that citalopram is a second-line drug. So I think it is time that NICE did look at the most recent Cochrane review and think about updating the evidence base around medication. The Cochrane review also mentioned duloxetine, which isn't used much yet within CAMS, and it would be useful for NICE to have a look at that and see what they think. I think it's also important to say there's certain drugs that shouldn't be used in young people. So one group is the old-fashioned what we call tricyclics, and that is because they have lots of serious side effects and aren't very effective for young people. And then venlafaxine and paroxetine shouldn't be used in young people either, because they're known to have more serious side effects.
How effective can antidepressants be, Bernadka?
So all we can say at the moment for this very highly selected group of young people with the least severe depression, with the least complications, they seem to produce a relatively small effect. However, in another review of these medications, as well as psychological treatment, that review found that fluoxetine was just as effective as psychological treatment. So, it depends on the data you specifically look at. But overall, I think it's fair to say they've been shown to have a small to potentially moderate effect for depression. But on the other hand, if you look at the data for cognitive behaviour therapy and depression, that's also been shown to have a small to moderate effect overall. So in terms of effectiveness, there's not that much to choose between either of them.
So Bernadka, given the gaps in the data that you described, are there circumstances in which you'd prescribe antidepressants to a young person? And what sort of considerations do you have?
Everybody's different. So it's a nice talk about a person-centred, but also values-based approach. In other words, finding out what is important to that young person and their family as well if they're involved. And also understanding, the practitioner needs to understand where they're coming from, what their values are, because some practitioners might also, sort of be against medication or, more pro-therapy or vice versa. So we all need to be really aware when we're practicing about how we convey the messages. But yeah, everybody's different. So some young people, and particularly boys, for example, struggle to talk about their feelings, and some people prefer to take an antidepressant. And if that's appropriate for them, then that, it could be considered. But I've met many young people who are really reluctant to take medication, and that's important to recognise. That's a completely, it's a reasonable position to have. And everyone is different. It's important to have those collaborative discussions and think about the risks and the benefits, both of taking antidepressants, not taking them, and also the same as psychological treatment, because that comes, that comes with a commitment, a need to sort of talk, an ability to be able to talk and share feelings, and that some young people struggle with that. And I guess finally, your experience with antidepressants, I wouldn't see them as a cure-all, but for a lot of young people, it might just be that first stepping stone to then start to give you the confidence, might help you sleep, might help your anxiety a little bit, might make you feel a little bit better, give you a bit more energy. And then you're in a better position to help yourself. And for some young people, they might not have been able to access talking treatments without that, but once they're on an antidepressant, they're more able to then engage in those sorts of discussions and then make the best use of talking treatments to continue to work on their recovery, and also to think about, relapse prevention for the future as well. So it's complicated.
One issue that's frequently raised with antidepressants is the possibility that they cause suicidal thoughts. I imagine this is absolutely terrifying for parents and must be in the forefront of doctors' minds when prescribing. Bernadka, how do you deal with this concern?
That's been a hugely controversial issue for a long time. So in terms of the data around suicidality and antidepressants, it's been shown that roughly 1 in 50 of young people who receive an antidepressant might experience an increase in terms of thinking about harming themselves or actually harming themselves. So 1 in 50 young people taking antidepressant might have that experience, compared to those taking a dummy pill. So on that basis, it's important that we do advise everybody, or carers as well, to keep a close eye on the young person, and for the child psychiatrist who's prescribing medication to make sure that they keep in touch regularly and review over those first few weeks. It seems to be the greatest risk in the first few weeks, but again, it's for a small number of young people. But there's two things I'd like to highlight about that evidence. Firstly, again, that evidence was based on all those trials that we talked about, which were based on young people who didn't actually have any suicidal thoughts to start with. They weren't done on young people who have suicidal thoughts, which is the young people we see and might consider prescribing for. So again, we don't know what the side effects might be or how important that issue is in young people who are already feeling really desperate and suicidal. And the other point I'd like to highlight is that if it's upsetting data, but there has been a study that's looked at all the young people have taken their own lives. And looked at, we call them autopsy studies. In other words, they look at blood levels of antidepressants in that young person's system and found that, over 90% of young people were not taking antidepressants at the point that they tragically took their own lives. So that very much points to underprescribing, potentially young people who are feeling really desperate. And so it's not that antidepressants potentially lead to young people taking their own lives. It's young people not receiving help early enough, and some of them may well have benefited from antidepressants, but it comes too late for some young people. So I think it's really important, again, to weigh up the risks of an untreated severe depression versus possible adverse effects of medication. And of course, that will vary considerably, with each young person.
Thank you, Bernadka. And Felicity, can I ask how you are now?
Things are going pretty well. I'm in my final year of medical school, which has not been an easy journey, but it was important to me to do this. After my experiences, I knew that I wanted to work in mental health. And I suppose it's really cliche, but my thought was, what a waste to have experienced what I experienced, and to have, it felt like I lost years of my life. What a waste to experience that and not use that to help other people. And so I trained first as a mental health nurse and decided that, I think I do want to be a doctor. I never thought I'd get into medical school. And so I applied and got in, and now, egg on my face, I'm in my final year. I'm applying for my first jobs as a doctor, and I hope to be a psychiatrist. I take antidepressants. I find them very helpful, but they are just one part in the list of things that I need to do for my mental health. I need to get enough sleep, lots of exercise, socializing, rest, because it's really easy to burn out when you're doing something like medicine. And I find antidepressants are probably an enabler more than anything else. I don't think they fix me. I don't think they cure me. And I do also go through periods where I feel really miserable. And I would say periods where even on antidepressants, I feel depressed. But I'm very good now at sort of, I would say, almost like sending up the flares. As soon as things start to feel bad, I'm pretty good at sort of telling my friends, telling my family, telling the medical school, all those support systems, I'm having a really rough time at the minute. I might need a bit of extra support. And I've never had a problem with that. But I don't know if I could have said that when I was younger, but I can say it now.
Thank you very much. That's very heartening to hear, Felicity, after all you've been through. I'd like to finish the podcast now by asking each of you for a take-home message from our discussion. Bernadka.
All young people have the right to have access to talking therapies as soon as they start to struggle. But some young people may well benefit from antidepressants, but that should be done as a collaborative decision together with a child psychiatrist or someone experienced in prescribing for young people. And just the last take-home message is, yes, of course, we do need much more research in depression, children, young people, both for antidepressants and for talking treatments. But it's really important that we have the research infrastructure to be able to deliver that.
Thank you. Felicity.
Everyone's experiences are so valid, and I would hate for anyone to hear that mental health services aren't what we would necessarily hope they are, or the provision isn't there, and think, well, I won't ask for help. I think it's really important to ask for help, and I wish I had sooner. And as we've talked about in this podcast, if that's a teacher at school, if that's a friend, if that's a relative, please, please, please say, I'm having a really rotten time. Even if you don't know how to describe it yet, just, as I said, send those flares up, let people know you're struggling. It's so important.
And congratulations to you, Felicity, on your journey to recovery. And I'm sure you'll make a fabulous child-listening psychiatrist. Welcome to our profession.
Thank you.
Thank you very much, Felicity and Bernadka, for sharing your experience, insights and knowledge of young people with depression. We've heard today of the rising numbers of young people with depression and how services are struggling to provide a timely response. But there is help available for young people with emotional problems, starting usually with their GP, though a new initiative is making help available in schools. Talking therapies remain the mainstay of treatment for young people with depression, but there are times when antidepressants could be the right choice. we've heard of the dire need for more research into these drugs in young people. Nevertheless, the research today supports the use of some antidepressants and suggests that others should be avoided. So, huge thanks again to Felicity Jane Allman and Bernadka Dubicka for talking to us today. This is an episode of the NIHR podcast. I'm Helen Saul, and thank you for listening. If you have any thoughts or comments on this or any other episodes, please contact us at ced@nihr.ac.uk or via our Twitter channel @NIHR Evidence. For more information about NIHR Evidence and to see our collection on antidepressants in young people, do visit our website, which is evidence.nihr.ac.uk.